All right, so you're about to start your clinical clerkships. You're probably feeling this wild mix of excitement and maybe, just maybe, a little bit of sheer terror. Totally normal, I promise. Think of this as a little guide from a mentor who's been exactly where you are. It's all about giving you the mental toolkit you need to not just survive on the wards, but to actually thrive.
So here's our game plan. We're going to start by talking about why this transition feels so hard. Then, step by step, we're going to build the tools you need to really start thinking and speaking like a seasoned clinician.
First things first, let's just get it out there. Why does this jump from the classroom, from your books and lectures, to the real-life hospital wards feel so overwhelming?
You're going to notice this on day one. I guarantee it. A resident will see a patient for like 2 minutes and already have a plan while you're still just trying to get the story straight in your head. It's a feeling every single med student has. But listen, this has nothing to do with being smart. It's about the different software your brains are running.
And this slide just nails that difference, right? As a student, you are in the learning phase. You are forced to use that slow, analytical, step-by-step thinking because you're busy building the mental library that residents can access in a split second. So feeling slow? That's not a bug, my friend. That is the feature. It means you're doing the hard, foundational work of actually becoming a doctor.
Okay, so to really get that difference, you have to understand the two basic operating systems in your brain. And learning how to switch between them, that is the absolute core of expert clinical reasoning.
You can see the trade-offs right here. System 1 is your gut instinct. It's fast, it's efficient. You see a butterfly rash and bam, your brain just screams lupus. But it's also super prone to error. System 2, that's your slow, methodical detective work. It's safer, but man, it is exhausting. Now listen, your job as a clerk is not to have a great System 1 yet. Your job is to get really good at using your System 2 to check the work of your System 1.
So what's the secret sauce here? It's this skill called metacognition. It's basically thinking about your own thinking. You have to develop this internal check engine light that flashes whenever a diagnosis feels a little too quick, a little too easy. That's your cue to hit the brakes, slow down, and verify everything with System 2.
Okay, so if System 1 runs on patterns, how in the world do you build those patterns in your brain? Well, the answer is you have to consciously create something called illness scripts. Now, an illness script is way more than just a list of symptoms you memorize from a textbook. I want you to think of it more like a rich, detailed character profile for a disease. It's the complete story. Who gets it? How does it behave over time? And what does it actually look like when it shows up in a person? Let's take a pulmonary embolism, a PE. The script for a PE is not just shortness of breath. No, it's a very specific story. It starts with a specific kind of person, someone who just had surgery or a long flight. It unfolds over a very specific time frame, suddenly, over minutes, and it presents with a classic trio of findings. Now, if your patient's story doesn't match this script, say their cough has been getting worse for 3 weeks, you can feel pretty confident that PE is way less likely.
Okay, you've got the basic tools. Now we have to talk about the dangers. Because your fast-thinking System 1 loves to take shortcuts. And those shortcuts can lead you down some very predictable paths to making a mistake. We call these cognitive biases. First up, and this one is a classic, is anchoring bias. This is when you latch on to the very first piece of information you get, like, say, the diagnosis someone wrote in the triage note, and it just colors everything else you see. You've dropped an anchor, and now you can't move. This is such a classic and frankly dangerous example. The note says asthma, so you anchor on it. You stop being a detective and you start looking for clues just to confirm that first idea. You might even completely ignore a massive clue, like a swollen leg, because it doesn't fit the asthma story. The way you fight this is simple. Always ask yourself, if I knew nothing, if I hadn't seen that note, what would I think is going on? And next up is its evil twin, premature closure. There's a saying in medicine, when the diagnosis is made, the thinking stops. And this bias is exactly why that is so dangerous. You find an answer that makes sense and bam, you just stop looking.
This happens all the time. Patient comes in, cough and a fever. Must be pneumonia, right? Case closed. But by closing the case early, you completely miss that subtle heart murmur that was pointing to something much, much deadlier. The prevention for this is so simple, but it is so powerful. You have to force yourself to always ask, what else could this be? Always generate at least 2 other possibilities.
Look, here's a practical checklist you can actually use before you present any patient.
Just building in a simple 10-second diagnostic pause to run through these questions can literally be the difference between a great diagnosis and a terrible miss.
All right, let's switch gears. It's not just about what you think, it's about how you communicate that thinking. A huge part of your clerkship is learning how to present a case. And to sound professional, you have to learn how to translate a patient's messy, real-world story into the precise language of medicine. The secret weapon for this translation is a tool called semantic qualifiers. These are basically professional-grade adjectives, usually in opposite pairs, like acute versus chronic, that add structure and crystal-clear meaning to your description of a patient's problem.
I want you to think of this as your personal translation dictionary. You're taking the raw data, the stuff the patient actually tells you, and you're converting it into the professional term that neatly categorizes it. This is how you stop just listing data and start presenting real clinical information.
And boom! Look at the power of that translation. The after version isn't just shorter, right? It's a diagnostic power tool. When you use words like chronic and progressive, you are instantly telling your attending which illness scripts you are already thinking about and which ones you've ruled out. It's a total game changer.
Finally, let's put it all together. Everything we've talked about culminates in the single most important sentence you will say on rounds. It's called the problem representation, but everyone just calls it the one-liner.
And guess what? There's a formula to it. It's beautiful. You start with the host, who the patient is, their key risk factors. Then you add the time course, acute or chronic. Then you layer on those key qualifiers we just talked about, and you wrap it all up by naming the syndrome. You follow this formula and you transform a long, rambling story into one perfect, powerful sentence that points right at a diagnosis. So as you get ready to walk onto the wards, I want you to burn this into your brain. Your job is not to be fast like the residents. Your job is to be safe. It's to be methodical. It's to be deliberate. Because all that slow, careful System 2 thinking you're doing every single day, that is the raw material your brain is using to build the expert, intuitive System 1 you'll have for the rest of your career. Embrace the slowness. That's where the real learning happens. So I'll leave you with this final question. We've gone over a lot of stuff here, but this isn't just about knowledge, it's about building habits. These are skills you have to practice. So I want you to think about it right now. What's it going to be? Which one of these habits are you going to intentionally work on during your first week to start building that rock-solid foundation of clinical thinking?